My name is Houssam Younes. I'm one of the vascular surgeons here, and we'll be talking about the diagnosis of DVT and PE. I think the slides are out of order. Can we please, yeah. So we're using A. There you go. So deep vein thrombosis, approximately 600,000 people affected with DVT, and 1/3 of those patients will, the DVT will break and will cause pulmonary embolism. I think the screen is really low here. Oh, that's high. So what's bad about DVT? Acutely, it causes disability. It causes swelling and pain of the legs. It can break and causes pulmonary embolism in 25 to 30% of those patients, or it can cause compartment syndrome, also called as phlegmasia, which causes limb loss. And the long-term risk of DVT is post-thrombotic syndrome, which is pain, swelling, hyperpigmentation, and ulceration, also venous claudication. So we talked about post-thrombotic syndrome. What else can happen? Chronic condition in 30 to 70% of DVTs within 2 years, and 90% is unable to work due to leg symptoms 10 years after iliofemoral DVT. And it causes, the DVT itself, it causes irreversible damages to the valves because the clot stays behind the valves, and those are the hard areas to eradicate. This is example of the venous stasis ulcers. It forms usually around the ankle, where the veins are most superficial and less soft tissue around there. It causes stasis dermatitis, hyperpigmentation, pain, and a lot of drainage. This is an example of post-thrombotic syndrome. You can see severe reflux and very large varicose veins, which eventually may cause venous stasis ulcers. So classification of DVT, there's distal DVT and proximal DVT. Distal DVT is in the calf. Anything popliteal, femoral, iliac veins called proximal DVT. And 90% of the PE is caused from big clots, which is the proximal DVT. How do we diagnose DVT? As anything else, history, physical, imaging. So we'll go through each one of them. History, we go through the risk factors for DVT. Prior DVT is the #1 risk for DVT, age above 40. Anything that can make the patient hypercoagulable, like cancer, pregnancy, immobility, or syndrome of hypercoagulable disorder. Differential diagnosis. The top of the differential diagnosis is muscle strain or a tear, hematoma, which is seen in 40%. Also, keep in mind the post-thrombotic syndrome, because the patients with the #1 risk for DVT is previous DVT. So when patient presents with a swelling or pain, then you think it's DVT, but actually it can be post-thrombotic syndrome. Physical examination, what you will see on physical examination. Swelling, focal tenderness, pain in dorsiflexion, Holman sign. Be gentle when you do that. Patients don't like that. Dilated superficial veins showing outflow obstruction at the same time compensation, as Dr. Sheehan showed. When the deep system is thrombosed, the blood trying to flow back through the superficial system. Erythema and warm skin. However, the clinical assessment is inaccurate because HMP is not sensitive or specific. 75% of the patient suspected of having DVT actually have alternative diagnosis. On the other hand, 50% suspect an alternative diagnosis, they have DVT. And this is the Wells score, kind of help you have the pretest probability of a patient having DVT, which is mainly giving points for every risk factor and points on the physical examination. For example, if the patient have active cancer, get 1 point, paralysis, recent plaster immobilization of the lower extremity, you get another point, localized tenderness on the examination, 1 point, recently bedridden. So you get the idea. For every risk factor, you get 1 point, and then when you add them up, you have the high probability if it's 3 and above, moderate probability 1 to 2, and low probability if it's less than 1, which is 0. So what does that mean? If the patient gets high score above 3, 53% chance of having DVT. Low risk is about 5%. And we'll see how that helps us in a little bit. D-dimer is the fibrin degradation product of a cross-linked fibrin. Usually it's less than 500 nanograms per millimeter. High sensitivity, low specificity. What does that mean? You can rule out, but you can't really rule in. Many false positives. So as we said, if it's negative, it's most probably the patient does not have DVT, especially if they're low risk. However, if it's positive, it can be anything. Malignancy, DIC, increased age, infection, pregnancy, trauma, inflammatory condition, or atrial fibrillation. So again, it's helped to rule out. Ultrasound, the golden standard. You can perform proximal compression ultrasound or whole leg ultrasound. The proximal compression ultrasound is 4 points only. You compress on the femoral veins, the popliteal veins. You can do it yourself. You don't need the vascular lab. However, you can miss calf DVT, which 15% of those calf DVT can propagate into DVT. So when you do proximal ultrasound, compression ultrasound, you can rule out large or proximal DVT. However, you still have to perform additional tests like D-dimer and repeat the test within 7 days. All you do whole leg complex duplex. If it's negative, there's no DVT. How's the femoral vein flow usually? It's spontaneous, not pulsatile, phasic, changes with respiration. Every time we take a deep breath, we create negative pressure in the chest. That's pull the blood up. We'll talk about that. If you lose that physicity, that means something in between the leg and the heart, which most probably is the thrombus in the iliac or the IVC veins. It augments with compression. If you compress the calf, again, the outflow should be open and it should increase. And stop with Valsalva, the other way around. You create positive pressure in your chest, obstructing the outflow. Venous, so what's the diagnostic criteria of DVT? This is very important. You will get it almost every year on your in-service exam. They love this question. The most sensitive sign is venous incompressibility of the veins. And I had this question asked in 3 different ways on my RPVI. They ask you in every single way, one directly, and the second one was more scenarios. Which of the following scenarios is the most sensitive that the patient has DVT? And they try to trick you by one of the answer was, you see clot in the femoral vein. It's obvious DVT, but acute DVT, the question says acute, it's incompressibility. Chronic DVT, when you see the clot. Many acute DVT still don't see the clot yet. And the sensitivity, again, the opposite of everything I described. Absent diminished spontaneous venous flow, absent of respiratory variation, absent or complete color filling of the lumen because there is a thrombus there, or increase in the diameter. The thrombus will stretch the vein, so it will increase in the diameter, and the valves will become immobile. With the chronicity, the vein becomes more prominent. You see the wall as well. And the most sensitivity, single point is incompressibility. However, the more signs you have, the more sensitive test you have. And this is an example of popliteal vein DVT. You don't see color flow in the vein in either images. And again, I can't emphasize enough, incompressible. So what's the diagnostic algorithm? We determine pretest clinical probability. History. Is the patient high risk for DVT? Measure D-dimer to rule out. And then combine both. If the patient has low, moderate pretest probability and negative D-dimer, there's no DVT. The patient has positive D-dimer or moderate high risk, you have to get an ultrasound. Treat all DVTs, absolutely. So now we talked about 25 to 30% of the DVT will break and cause pulmonary embolism, and the first manifestation of PE, many times it's fatal PE. Am I out of time? Okay. So DVT annual incident, 530,000. In Europe, it's more than 1 million. And up to 200,000 deaths in the US annually caused by pulmonary embolism. That's more deaths than AIDS, motor vehicle crashes, and breast cancer combined. So if you want to save lives as a trauma surgeon, rethink that. Just treat pulmonary embolism. Pulmonary embolism, very, very important. How do we classify pulmonary embolism? Massive, submassive, minor. So what's the difference between massive and submassive? That's when most of us get this wrong. Massive is large clot burden. However, there is hemodynamic instability. If the blood pressure is normal, that's not massive, no matter how big the clot is. That's submassive. And the most common is the minor. So here, the massive, when we say hemodynamic instability, is systolic blood pressure less than 90, and 58%, 90% mortality, very serious disease. And the high early mortality is mainly due to right ventricle dysfunction. Submassive, they can present with large unilateral or bilateral thrombus. However, there is hemodynamic compensation with right ventricle strain. It has to have right ventricle strain to be submassive. And 22% mortality within 90 days. Minor small thrombus usually present as pleuritic pain or tachycardia, hemoptysis, or cough. Very low mortality. Clinical presentation, dyspnea, chest pain, pleuritic chest pain with hemoptysis, which most probably the infarcted part of the lung. Non-specific signs, tachycardia, tachypnea, palpitation, lightheadedness, fever, cough, wheezing, and rales can be seen in other diseases. But the possibility of massive PE should be considered with anybody with near syncope, sudden near syncope with shortness of breath. Tachycardia should be considered for PE. Biomarkers, if you look at the biomarkers, they all show heart strain. I'll talk a little bit during the treatment of PE about that. Increased troponin, the heart is under stress. BMP, stretch atrium. D-dimer, as we talked, is very sensitive but not specific. Imaging, gold standard is CTA. MRA and iodine allergy in pregnancies, you can consider that. VQ scan, very confusing. Low probability, moderate probability. What would you do with that? Echocardiogram, you look for right ventricular strain, even left ventricular strain. And intravascular ultrasound, it's invasive, but it still can be considered, especially if you're considering therapeutic options. This is an example of PE on CTA. You see the thrombus filling the right and left pulmonary artery with the piece lodging distally. This is MRA. Do you see the PE where the arrow is? And this is the VQ scan where you see ventilation is normal. However, areas of the lung is not perfused, which causes ventilation-perfusion mismatch. Treatment options is going to be in another lecture, but observation, never really. High-dose heparin therapy, everyone gets heparin. Thrombolytic therapy, we'll talk about the indication during the treatment in the other lectures. Mechanical thrombectomy, pharmacomechanical thrombectomy, or surgical thrombectomy.